Hello and welcome to the Raising Kellen podcast. My name is Marsh Naidu and I blog at raisingkellen.org, where we curate resources for parents raising children with disabilities. On today's episode 123, we chat with Woody Tatman. Woody is an occupational therapist with West Tennessee Healthcare, in addition to being a certified driving rehabilitation specialist. As always, remember the content provided on this podcast is for your information only, and if you seek advice for your specific situation, to contact a trained professional. Today's episode is brought to you by Teletherapy Services. So grab that cup of coffee, put your feet up, and get ready for some awesome conversation. Woody Tatman is an occupational therapist with West Tennessee Healthcare, and he presently works at West Tennessee Healthcare in Brownsville, Tennessee. Woody is a certified driving rehabilitation specialist, and I am so glad he is joining us today. We have a ton of questions to ask about adaptive driving. I also want to just give a shout out to Woody's wife, Beth. He's also a PT, as well as his two beautiful daughters, Maria, who lives in Jackson, and Leah, who lives in Chattanooga. Thank you, Woody, for joining us today.
You're quite welcome. Thank you.
You have an extensive professional career as an OT, and I'm really interested in your role as a certified driving rehab specialist, Woody.
Being a certified driving evaluator is kind of a specialty area within the area of therapy. You don't have to be an occupational therapist. You can be a physical therapist. Or even just a driving evaluator. There's different criteria that you have to satisfy to get that certification. And it's a nationally recognized certification through the ADED national organization. So it requires education and testing, and then especially about a year of training underneath somebody that's a CDRS. So, for instance, the program here in West Tennessee was started in 1996 with an OT by the name of Darlene Cox. And then around 2007, she thought she was getting ready to retire. So they were looking for somebody to take the program over. So I took it over in 2008, became certified, and has moved on from there. We do have another therapist in Lexington. His name is Cody Stovall, and he's certified as well. We used to both work together in Jackson, and then COVID changed everything for everybody. So he's in Lexington and I'm in Brownsville. But it just affords you the level of a qualification and quality program that when you're being evaluated and trained by somebody that is certified, that you're getting the most up-to-date and accurate information with regards to, the different state level regulations.
Yes.
And who is also certified and competent to make the modifications to a vehicle if you need those modifications. So there's quality assurance programs put into place nationally.
Woody, are you doing the adaptations to the vehicle, sir, or are you also kind of testing to see if someone can drive or will be safe driving? Is it driving lessons?
Well, what it is I'm certified to do an evaluation on somebody, and that opens up a whole realm of possibilities. For instance, I can evaluate somebody to determine if they should or shouldn't be driving in the elderly population, or somebody that's had a head injury, regardless of the age. But based upon the diagnosis, whether it's a stroke, a head injury, a spinal cord injury, Alzheimer's, dementia, or any other type of mind-altering situation that's going on. So I can evaluate somebody, and then also with another population of some level of disability or handicap, would be evaluating somebody to see if they've got the potential to learn how to drive with or without modifications. And those modifications could be as simple as a spinner knob, a little hand knob on the steering wheel, to hand controls, but also evaluating people with autism, who may not need any modifications. They just need the time. It's going to take extra time to teach them how to drive and be comfortable. It's a medical approach. But I don't do any of the modifications. We have modified vehicles with different adaptations that we can take on and off to try with people to see what's going to be the best modification for them, then make the necessary recommendations so a certified installer can modify your vehicle, because you don't want anybody just drilling holes and cutting and moving things around. They don't know what they're doing.
Okay, so take, for example, a young adult with, say, autism, right?
Mm-hmm. Right.
How will that approach work, Woody? Will the parents need, or the school need to contact you, or I'm trying to figure that out. How would that work?
The best thing with that I recommend to a lot of parents is if they can get established with the vocational rehab services. So they get a case set up, get a case manager with Voc Rehab. Usually it's in the junior or senior year of their high school. They set up a transition plan to where in your IEP, you're going to transition from high school on into whatever further education you're going to go into. And part of that transition plan is being employed. And so also somebody that has good transportation ability, independently driving, they make a much more dependable employee. So vocational rehab services will make the referral for driving and pay for it. And that's the other big kicker, is that this isn't paid for by anybody except vocational rehab, workers' comp, and sometimes the VA. Everybody else gets to pay out of pocket. Wow. And that can become rather costly. And then on top of that, you might have to pay for your modifications. So for hand controls, you're looking at maybe about $2,000 just for the hand controls. And it goes up from there. That's simple. That's an easy adaptation. But if you have to do high-tech electrical modifications, that's a whole nother ballgame. So to pay for the evaluation and to pay for the training, and if I'm talking with somebody with autism or cerebral palsy or some other type of developmental delay, we could be talking months of training, a couple days a week. And that quickly can add up to thousands of dollars that would be out of pocket from the family. So I always recommend, if they haven't pursued vocational rehab, because it's a state-funded program that will pay for the evaluation, will pay for the training, and I try to do it as judiciously as possible. Not to keep them for 30 times if I can do it in 10 times. And the part of the process too is do the training with the modified vehicle if that's so necessary, and then go take the road test and get their license, and then they can get their vehicle modified. And then also on that same vein, I always require and insist that whomever I'm working with has gotten their permit before we get behind the wheel. I'm not going to help you with the permit. You've got to get the permit on your own. The permit's a written test. Okay,
I was just fixing to say that's a written, so that they know the rules of the road and the signs and things like that.
Correct. And then we will expound upon that. But you don't want me to take the time to sit there and spend weeks or months teaching you how to take a test, a written test. That's not money well spent. Mm-hmm. So I'm looking forward to spending the time behind the wheel. And if you can't pass the written test, then we're not getting the other one. So it's been a good process that way. So vested interest from the individual and from the family to get the permit first. But I will help you learn how to drive and then go get your driver's license.
You had the most amazing setup when we had our ability resource fair at Vocational Rehab in March of this year. You had an amazing setup with a steering wheel and attached to a brake foot pedal system. Can you talk more to that? Is that one of the tools in your toolkit?
Well, that happens to be a demonstration, a gadget that we got from that particular company that I really do like for hand controls, and they're based out of Canada. It's called Sure Grip. and they have about 4 or 5 different options for hand controls. So I can take that around and have a nice little demonstration set up to see how it's going to be set up with regards to the steering wheel and how it pushes the brake and how it pushes the accelerator. So just makes it kind of a nice little demonstration piece if I don't have the car with me. But in the car, I've got those same hand controls. In the van, we have a van that's in Lexington with Cody. We have hand controls in there as well.
As far as our senior population is concerned, you sometimes often hear kids say, Mom, it might be, or Dad, it might be time to put up the car keys and things like that. Is there objective testing that you can do to help the family make that decision? Yeah.
Most definitely. And it's the same test I do for everybody. Now, I may modify that a little bit. If I've got somebody that is cognitively intact and not having any trouble, maybe they just like a below the knee amputation or above the knee amputation on the right leg, and we have to look at some type of vehicle modification, or they have got diabetes. But with your elderly population, there's an extensive battery of cognitive tests that we can take them through. Many of them are the same testing procedures you'd have in a neuropsych eval. So it's simple cognitive problem solving, reasoning, memory issues, memory testing, but nothing is hard. It can be challenging. So we do a battery of tests, which take about an hour and a half to go through the clinical part. And then we go for a drive on the road. And then I compare how we did in the clinic to how we did on the road. So it's a very, very objective testing procedure. And I do the same test with everybody. And so I give everybody the opportunity to drive. Sometimes we never leave the parking lot. If you can't figure out what to do with the keys, then I'm not starting the car for you. You know what I mean?
Totally understand. Do they go in your vehicle or do they go in their vehicle?
They go in my vehicle. Well, it's a hospital's vehicle.
Okay.
And because I have a brake, I have an instructor brake on my side. So if we go in your vehicle, then we're just free willy out there. So I have no way of preventing somebody or for you from stopping. But with my car, we have a brake, and it does really well. So over the years, we've only had one accident. We got hit from behind, and so I can't control the guy behind us, but have prevented quite a few accidents out on the road. So, and that's the other thing. If somebody drives with us and they have difficulty driving, a lot of times they'll get back and they'll blame it on the car. And that's usually a pretty telltale sign, especially if you're 80 years old. You've driven how many cars? So, and the car we have is a pretty simple car. It's an old car. There's not a single bell or whistle on it. So it's not the car they come in is probably more technologically challenging than our 1997 Chevy Lumina. The car I had at the Resource Fair.
I got you.
Old car.
So I'm thinking now of, different patient populations. If someone was, for example, was a wheelchair user, what are some of the things that can be looked at to help support that patient or individual to drive?
Spina bifida. Or you're in a wheelchair and you're a paraplegic for whatever reason. We'll just keep it a simple paraplegic. So I have to look at a variety of things as far as accessibility to the vehicle. If they're a new person to driving, then we have to talk about what kind of vehicle are they talking about? What do they want? If they're a young 18-year-old or a 20-year-old male who's been a hunter, he's going for the truck. He wants that big truck. So then you have to think about getting in that truck, getting out of that truck. He's got a wheelchair to think about where's the wheelchair going to go. And so if you're young and strong, you can grab handles and pull yourself up into the vehicle, and you can get in some type of crazy positions to pull your wheelchair back up. But there's a litany of opportunities of adaptive equipment to move your wheelchair in or out of your vehicle. And then if you want to go probably a little bit more utilitarian, you go with a minivan that has a ramp that comes out. You drive your wheelchair into it. You either transfer out of your wheelchair into the driver's seat, or you sit in your wheelchair and you drive from the wheelchair. And there's a whole nother locking mechanism required for that. So you look at each individual need of each individual person. And what I've always tried to do is keep it as simple as possible. Because the more you change the vehicle, the more you add, the more you just have more potential for more things to breaking down and problems with it. Not to mention the expense. You look at a minivan with a ramp and hand controls and a lower floor, and you're looking at about an $80,000 vehicle. It's very expensive. And we haven't even talked about you move into high tech stuff. So now you're a quadriplegic, and you can drive your wheelchair with the joystick, but you don't have enough strength to drive with standard hand controls. So they can modify the vehicle with electric controls. So you drive the car with like a joystick, and the steering wheel can be modified as well. That becomes exponentially more expensive. And then going back to what you were saying about the elderly population, the evaluations, and me seeing them, usually they're a referral from their doctor because the families talk to the doctor, and the doctor's made the referral for the evaluation. And typically they're Medicare patients. So Medicare does not pay for this evaluation. So this evaluation, which is the same evaluation for everybody, costs them $517 for about 3 to 4 hours of time for me to determine whether or not they should or shouldn't be driving. Always we tell everybody that ahead of time, so there's no big surprises when they show up.
That's some good information, Woody.
And it's the downside of Medicare because they don't look at driving as a necessary ADL. And I tell people all the time, everybody in the Medicare office drove that day.
Yes, sir. They did.
Everybody drives. So why they don't reimburse for that? I don't know why. I don't know why. Even on our standard evaluation, it says in your goals, don't make any reference to driving. You can talk about community mobility, but anyway, I wanted to mention that so we didn't forget about that there is a cost involved.
Thanks, Woody.
With the younger population, that's why I recommend going through vocational rehab, because that $500 can become $1,000. With the training, every time we drive, there's an expense involved. So I'm saying it can get expensive.
How do you handle color blindness when it comes to, I mean to ask that with lights changing and stuff, is that something people can?
Well, color blindness is not, the state doesn't care if you're colorblind. The state doesn't care if you can't hear. The state only cares if you can see. And that's what I was going to go on to as far as vision. Vision's critical. The state requires a minimum of 20/40 vision out of at least one eyeball. They like both eyes, but it's at least one. And there's a special form. If you only have vision out of one eye, you have to have a document from your optometrist, ophthalmologist, or whomever to fix that. So anyway, but color blindness is no big. So what we learn is that if you're coming up to a traffic light, there's 3 lights, and so if the top one is lit, well, that's your stop. If it's the middle one, so it's a learning process, compensation. And so if it's something you've dealt with all your life, color blindness, you should be able to compensate and modify for that. Hearing, the same thing. If you can't hear, your vision's got to be spot on. You always have to be, so you'll have to learn how to, look at all your surroundings and be aware and scan from left to right, forward to back, which you're supposed to do anyway. But it becomes more imperative when you can't hear. So I do work with people with low vision. That's a very challenging thing to work with somebody that's dealing with bioptics. They've learned how to use bioptics, which is just it's a monocular attached to your glasses so that you can then adjust and see far off, your far distance, while moving about. But it's one thing to do that while you're walking at 1 mile an hour or half a mile an hour, strolling around the house. But when you're doing driving and learning how to use bioptics, it becomes a bigger challenge because now you're doing it 30, 40, 50, 60 miles an hour. And you've got to check that bioptic to see what's up ahead. For instance, a four-way stop, a traffic light, traffic. And so that's probably the hardest population I've worked with is the vision and the low vision. And it's a little unnerving when you zip through stop signs that they never see. And so it's a harder one for them to become comfortable for themselves while driving. So, but vision is hard. Vision is the kicker.
Woody, thank you so much for taking the time to talk to us.
You're welcome. You do it again.
Absolutely. I will see you soon. You have a great rest of the day, Woody, okay?
You too. Tell Kellen I said hi.
I will do it. Well,
I appreciate it. Thank you.
No problem. You take care, Woody.
You
Bye-bye
too.
now.
Bye.
Bye-bye. For those drivers out there interested in adaptive driving, here is a resource for you. It is ADED, the Association of Driver Rehabilitation Specialists, and their website is www.aded, that's ADED.net. Thank you for listening along on the podcast today. As always, remember, please leave a rate and review of this episode on your podcast platform. Today's episode is brought to you by Teletherapy Services. If you would like to reach us, you can contact us at raisingkillen, that's KELLAN, @gmail.com. As always, remember, get to the top of your mountain. This is Marsh Naidu signing off.